This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
Hello, and welcome to SG2 Perspectives. I'm your host, Tori Richie. Today, we're going to talk about cancer service line planning, and I am joined by a powerhouse of expertise. From the intelligence side, our cancer expert, Setu Shah, and then on our consulting side, I'm joined by two experts in this space, Melissa Threlkeld and Ryan Hallenbeck. Thank you so much for joining me. Let's dive right in. Where is the cancer landscape going over the next 5 to 10 years? What are some of those growth projections? How are perhaps incidence rates changing?
Yeah, Tori, it's always exciting when we get to join the forces of our intelligence teams. We focus on thought leadership and forecasting, and of course, having our consulting colleagues who are with our clients and get deep into the space. When we're thinking about that near term, long term, that high growth is, of course, going to be in the outpatient setting for cancer care. We're projecting about a 17% growth nationally over the decade, close in line with population there. The aging factor is going to have a big play. And then we know that younger populations are getting cancer diagnoses as well. So population, big play here. We know that 1 in 2 men and 1 in 3 women will be diagnosed with cancer in their lifetime. So this really is not something that picks races or age. It's all across the board. The big other thing that's going to drive that forecast is the growth in cancer survivors. We've talked about on intelligence that there are projections that talk about we're going to have that cancer survivorship grow up to 26 million in 2040. In 2022, there was about 18 million. So going up to that 26 million is going to be a huge influx of patients and survivors. Not only does that mean people who will potentially get recurrent disease, metastatic disease, but also people who will need that long-term care, both cancer-related as well as non-cancer related. We've always talked about how with some of the advances we've made in cancer care, folks may not die because of cancer, but rather with it. Anything you would add there, Melissa, Ryan?
It's important for organizations to understand that as we think about that growth, capacity is going to continue to be challenged. And we're seeing that really with the organizations we work with across the country is capacity challenges exist today, but they're going to continue to be even more in the future. And as we think about survivors, that's going to put pressure on all access points within the system because we know that survivors are continually, hopefully, continuing to engage with your organization from a diagnostic standpoint, usually from a surveillance standpoint, and a continuation of those touch points with their physicians throughout survivorship. So that continues to put pressure on an organization on the front end from cancer, but on the back end from a survivorship standpoint. And more organizations are starting to talk about how do they accommodate capacity for survivorship programs and survivorship visits and tracing those patients and keeping their arms around those patients as they continue on into survivorship.
Medical oncology continues to be a place that is strained by that access. And we hear from organizations that when you fill your medical oncology clinics with survivorships and not continuously thinking about what it means to repatriate back to primary care or have the patient directly engage in survivorship clinics, you fill that access and you limit that access for new patients, new cancer patients, new diagnoses. It's not only that capacity, but also access play as well.
That's a fantastic point when you think about access and availability of resources and maximizing the license of the team that you have in place today. Oncology is no different than most of the healthcare system. We've got workforce challenges across the spectrum. One of the primary ones is really going to be in that medical oncology space from the standpoint that we're projecting pretty significant shortages of physicians over the next 5 to 10 years. When you've got the coupling of increasing in demand, increasing survivorship, and a limit of the number of providers to take care of these patients, we're really going to be at a crossroads in future years. We need to start to think about how does some of that care model redesign start to happen? And what does that mean when we say top of license for your clinical care team? And what we work with organizations is around how do they maximize that use of APPs or that extender clinical team to take on some of that survivorship planning, follow-up care, but then also having organizations think about APPs a little bit differently. And they even start to take care of some of the earlier stage cancer patients. We'll get into this later on when we think about growth overall. So demand When we think about growth, and you think about, well, if you have like an outreach clinic or another location where you want to provide services, maybe the community is in deficit, that's also another space for your APPs to be extenders, to see follow-up patients, to see those that are less ill. And then finally, a lot of activity around this urgent care model for cancer and the APP team managing that urgent care population, which has clinical and quality benefits of keeping patients out of your ERs, but also allowing you to have access within your medical radiation oncology physician population.
The reality about the cancer landscape is how we are caring for these patients is rapidly changing with some of the innovation that's coming down the pike. Setu, I'll start with you. In your estimation, how does that affect the types of access points that need to be developed, the types of workforce that also need to be recruited into the system to ensure that we're offering that full program for cancer patients?
A lot of the advanced therapies that are here today, as well as in the pipeline that we've baked into our forecast, improved thinking about that improved access, relieving capacity, all of that together is pushing organizations to think about how do we redesign care? How do we think about different care models? Home is always the hot topic that organizations want to talk to us about. We haven't made as much progress specifically in the home infusion realm for cancer care. A lot of organizations are dipping their toes into this, but cancer patients just make up such a small cohort of this. Mass General Brigham looked at their hospital at home program a little bit recently, and out of more than 3,000 patients in their program, only about 50 had an active cancer diagnosis over a 4-year period, around that number. That study focused on a 4-year period. And we know that this is an increasingly hard space to focus time and energy on. Some of the regulatory payer and reimbursement headwinds, of course, we're not going to get too deep into that space, but that's a big part of it. We do see certain organizations making impacts here. So thinking about using virtual care for your high-risk patients, for your survivorship populations, thinking about using virtual care for psychosocial care. Melissa talked about survivorship. When we talk about younger patients getting cancer, that means they're really faced with understanding what this means for their life. Engaging them and connecting them with that psychosocial care is critical. Remote patient monitoring for outpatient CAR-T. We hear from a lot of organizations that the goal is to 100% be able to do CAR-T in the outpatient setting, as well as other cell-based therapies. So leveraging remote patient monitoring, virtual capabilities to help manage that patient outside of the hospital. And when they do need that complex care, you have other mechanisms for tracking that urgent care and the ED. You want to use those as levers, but ultimately having these other wraparound services in place to manage the patient. We heard from a lot of organizations that the outpatient place is a way to go with these cell-based therapies. They found that with one of their therapies, they had to do 12 administrations in the outpatient setting to offset the cost of one in the inpatient setting. So that financial model is driving the need for these new care models or revamped care models.
Anything else that you all want to hit on as it relates to the demand topic?
We're working with organizations currently in several engagements, but also how do I identify these patients much earlier on? A lot of them are presenting in later stage disease. And because of that, the complexity of those patients is elevated. And so a lot of organizations are looking at high risk programs in breast and colon and having dedicated clinics around those, which again, only increases the overall volume. Also interesting is this whole multi-cancer early detection testing. And that's the hot phrase that we're hearing. It's still new to market. There's limited tests that are available and there's an out-of-pocket expense for patients. But we're also seeing organizations and health systems think about how do we manage that population, knowing that they don't necessarily have cancer yet. They could have some early indications of a potential cancer diagnosis. And so there's some longitudinal follow-up that will be required. That's going to be another area of focus. And so you're starting to hear around dedicated clinics for high-risk patients, around virtual care. So there's also a shortage around genetic counselors. There's just not a plentiful amount of those resources available. So how do you start to connect with them in a virtual environment, but also speaks to some of that partnership. But there's third-party partners out there that we're helping to connect the dots on to make sure that that resource and service is readily available to a wide patient population.
Multi-cancer early detection tests and liquid biopsy organizations who are entering to this. One, it's more of that concierge patient capture approach with the goal of being able to retain that patient in the long term. You do this test and hopefully keep them for that downstream level of care. We even heard that there are savvy, really health conscious patients who are coming to providers saying, I want to optimize my health. I want this. This is not for all patients. We don't know if this will exacerbate disparities or not. So more to come on that. The critical component for these is imaging. We've been hearing challenges with diagnostic imaging. So thinking about your diagnostic imaging pathway capacity, patients want faster and quicker. When they don't get that, that's really due when they start shopping around. Reassessing your diagnostic imaging and supporting services, things like pathology, diagnostic imaging, they can make or break access, even though they're not at the forefront sometimes.
Anecdotally, I've heard of instances where it's been recommended by their provider to actually go to the ED to receive a diagnostic imaging service because there's such a backlog in the ambulatory imaging spaces. If we think then about some of the downstream consequences of folks showing up to the emergency department for what is truly a diagnostic test because they're not able to get an upstream, that then create other barriers to entry for your complex patients as well.
What we try to work with our clients on around cancer care is an ecosystem. We've got to make sure that that ecosystem is sound. The breakpoint of what you mentioned before around access to imaging. If outpatient access to imaging is not available, then there's other areas that the patient has to access to, which is higher cost and less convenient overall. So we oftentimes encourage organizations to think about their cancer service line as an ecosystem. What we oftentimes tell our health systems is cancer care is the most complex service lines of all service lines. And that patient has the opportunity to touch every single aspect of your health system, from outpatient, ambulatory, to inpatient, to surgery, to rehab, pathology. The list goes on. When you're thinking about that service line strategic plan, you've got to take all of those aspects into consideration, which feeds in nicely as we think about the demand, but then how does that feed into how our system's going to grow to help meet that demand overall?
Ryan, Melissa, I'm curious, what are you advising clients when they are approaching either the evolution of an existing cancer program or perhaps even the development of a new one?
When they're evaluating and considering a new cancer service line, whether that be a net new, they've never had a cancer service line before, or they're looking at their service line that maybe is not optimized, there's a focal point of here's what needs to be evaluated to ensure that we have a fully functional. And oftentimes what we start with is this idea around, do they have the right structure in place to help support that service line as a whole? So when you think about governance structures, how is this service line organized? What do the reporting structures need to look like? And then finally, how are they going to align us incentives? We then get into to start to assess, okay, do we have the volumes and the market necessary to invest in what is a very highly intensive capital, but also people and resource service line. And then we start to look at, okay, do we have the multidisciplinary teams necessary to support that patient population? Oftentimes that's starting small with maybe one or two tumor sites to do that exceptionally well and then advance from there. And then it gets into that ecosystem, so the quality of the other services that are available. And then finally getting into, do we have the right location for the right care at the right time?
One of the things that's imperative is also thinking about, do you have the right feeder systems to have an effective service line? And that's something not just for new program development, but that's something that every health system, even the most mature, even dedicated cancer centers, giving some thought to who are the providers that refer into your program and how can you expand that reach? Understanding from a breadth and depth experience, the aligned physicians that exist within your market and who are they aligned with and how tight is that alignment? And are there opportunities, are there vulnerabilities in that alignment to be able to disrupt some of those referral patterns? That's what growth is all about. The other thing that's really important that we work with organizations on is a physician does not equal a program. Organizations think we bring on a med-onc and a rad-onc in particular, and we have a cancer program. And we work with them to say med-onc and rad-onc are really at the end of the spectrum. You've got to go upstream. Surgeons typically feed med-oncs and rad-oncs. Upstream of surgeons are your specialists. Upstream of them are your PCPs. Upstream of that, in a lot of cases, could be imaging, especially as you think about screening. So it's really taking a look at that whole ecosystem or that whole continuum to say, where do you have strength along that continuum and where do you have opportunities to lose patients on that patient journey in the continuum? And that's where survivorship becomes important, because I can speak to real life examples of patients who've gone into survivorship and the health system they've been treated at doesn't have the services they need as a part of survivorship. So they go to another health system and you run the risk of them finding that health system to be easier to access, to be more patient friendly, to be more timely to get a patient in, and you could lose them from your system then at that point and beyond. So really important to also think about the ecosystem of cancer and how to grow along each of those access points.
That makes a ton of sense. And Ryan and Melissa, when I think back to a conversation that the three of us had earlier this fall, you spent time going through what is the growth process that you ground many of your clients in as you're scoping out these service line or programmatic specific opportunities. Could you perhaps give a brief overview of how you customize or add nuance to that process, keeping some of these cancer considerations in mind?
So what does that process look like at a high level? The answers to these questions, so we ask typically 6 to 7 questions of most organizations, but the answers to the questions really drive where do we go next when we're thinking about strategy, particularly about expansion. So the first question that we laid out is being clear on what is your goal. We talked about no margin, no mission, but also being really clear about your mission, because it used to be that most organizations tried to be all things to all people, and we just can't afford to do that anymore, not just from a financial perspective, but from a resource perspective. So that would be question number 1, is defining your goal. And that really leads us down the path then, as we work with clients, of where we want to focus. The second question typically is, where do you focus? And we like clients to think about, what is your North Star? Where are you really focused as you think about expansion? What is the goal of that expansion? Is it to meet an unmet need in maybe a rural area where patients are having to travel further? Therefore, you go back to that question of margin versus mission. So we're working with a client right now that has a vast geography over multiple states for their health system. And we're working on a cancer plan. And a part of the question that we're having to ask is there an opportunity to put an access point in a market where you may not make money, but it's the right thing to do for the patient to provide services, particularly in a rural area? Really important to understand the goals and where do you focus. The third question we ask is, how do you differentiate your services? Or said another way, what gap are you filling that's different in a market than other competitors have filled? That's really important to understand, because differentiation is the key. It used to be that cancer patients had dedicated cancer centers or academic medical centers as the only point of access for them. Now community systems are really doubling down in cancer, and that's providing a lot more access for patients than we historically had. So now the question becomes, how do you differentiate? If there are 5 major cancer players, which is true in some big metropolitan areas, what makes patients come to you? Are you going to differentiate on the services you have, the programmatic elements you have, the marquee physicians you bring? Are you going to differentiate on innovation and clinical trials? Or are you going to differentiate on ease of access and patient experience? So being really clear about that. After we think about what gap we're trying to fill, then we transition into where's our center of gravity.
I'd like to build on the point that you talk about competition. What we're seeing also in the cancer space is you've got the competition that's in front of you today. So those competing health systems, you could have 4, 5, 6 competitors in a respective market. The other thing I think is the competition that's not known yet, and where we're starting to see some real investments of multinational, highly recognizable cancer brands going into new communities and partnering with community hospitals. What does that mean for competition moving forward? And what does that mean for differentiation? And now that you've got a national brand that's coming in to provide care in a consistent way, what does that mean for your program, but even potentially for your volume? Taking that lens of here's your competitors now, but then also maybe scanning a little bit more broadly to say what could be the competitors in the future that if we don't solve some of these problems or some of these gaps that we have, we could be at a vulnerable point overall.
Some of those competitors have changed over the years. It's no longer just providers. Now payers are becoming competitive in the sense that they're creating narrow networks or also creating centers of excellence with criteria that are allowing organizations to either be a part of that center of excellence or not. And then also big employers that are starting to say my number one cost when I look at disease within my employee population is cancer, and we're spending a ton of money on that. So direct to employer plans and competition that creates within a community. If there are 3 big businesses and 3 big employers and they go with a particular model of approach for cancer care or even screening and diagnostics, then that provides some competition that didn't historically exist. It's a combination of a lot of different pressures that are creating more and more competition today than we've ever seen before in the cancer space.
We would be remiss if we also didn't acknowledge the private oncology groups and the PE-backed oncology networks. Historically, we've seen them as practices. Now they've grown into groups, and some of them have even grown into networks. We see oncology and urology partnering up together. When we think about how do they differentiate, I see them as excelling in access. I've had conversations with cancer centers thinking about how do I operate more like a private oncology group? Health systems and some of these cancer centers are very niche. They're very clunky, but they're increasingly thinking about how to be more nimble from an access perspective.
I think that feeds really well into the next question I oftentimes ask. With a growth or an expansion opportunity, does that improve or enhance access overall? That feeds nicely into the new location. Does that allow us to reach a new patient population or an underserved community overall? Does it also potentially allow us to retain some of the patients that are in our system today? If we think about a health system in their expansion, does it allow us to retain some of that patient population? And then coming up with some creative strategies, how quickly we get new patients into the system. Is that a benchmark that we're tracking very closely? The other big one that we see systems monitoring closely as well is around this idea of diagnosis to first treatment. How we measure that has implications of, do we have opportunities within our operations, within our current portfolio of services that we provide? That just allows us to continue to track and monitor how we're doing around access. The final one that is relevant and important to this conversation today is around how are we enhancing care coordination? Back to that differentiation conversation, some smaller systems are okay if we can improve access, but then also once the patients are receiving care from us, how do we ensure that we coordinate care to maximize and reduce the amount of friction that can take place in the highly fragmented service line at times? And it gets back to that enhancing care coordination. So around navigation, other supportive services, and can we extend navigation farther into that patient's cancer journey so that we've got regular touch points along the way. So therefore the patient feels like they're better connected and better informed around their treatment plan. And we've got good research and data to show us that those patients that are better connected to the system feel more informed and are helped with a cancer navigator. They also are more adherent to their treatment plans. They're more adherent to do their follow-up visits, and all of those things have a tangible outcome, not only for the patient and the outcome from their cancer treatments and protocols, but then also for the health system to ensure that that care is being received in a timely fashion.
I talked with the organization in the Northeast who nurse navigation is not something new in cancer care. They're thinking about a concierge navigator. That means they've leveraged SG2 data, they've leveraged their cancer registry data to identify areas with growth, hopefully unengaged patients, and having the navigator go out into these areas, work with the primary care, all the feeders of cancer care delivery. So thinking about your radiologist, OBGYNs, primary care, all these individuals who are so critical into building that funnel. And so that's an example of how we've seen that navigator model evolve. Oftentimes, the economic foundation is based on the operations of securing the funding for navigation, but there are creative ways we've seen organizations push on that.
The most important aspect of cancer planning and the idea around demand and growth is around keeping the patient at the center of everything that you do. And so what matters most to cancer patients? One being timely access to care. That seems to be paramount, that patients are choosing providers for those that they can get access to and they build a level of trust with. One thing in the past was always my primary care provider, my gastroenterologist, my OBGYN has recommended that I go to see this medical oncologist. Patients are willing to take that at face value, but if there's any breaks around, can I have access to them? Can I build up trust? What's that patient experience like? What we're also seeing programs invest more heavily in is second opinions. Patients are out there actively seeking second opinions. And so what's your second opinion like? So that way that's a new access to patients that you may not have had before. The other thing too is how do we continue to limit fragmentation? We're seeing a lot more investment in development of cancer hospitals, additional investment in outpatient cancer centers. And it's not the traditional model of medical and radiation oncology just being under one roof and everything else being separate. It's this idea of bringing all the specialists to the patient and having all of those services available under one roof. So you've got even sometimes primary care, but you've got the specialist in GI, OBGYN, pulmonary, etc. And then you've got the surgical specialist, medical oncologist, radiation oncologist. So again, that patient doesn't have to travel to 6 different locations through their cancer journey. They're coming all to one. And then this idea of creation around multidisciplinary clinics has really been effective. But it's been interesting over the last couple of years, more investment, and you're seeing it in the news of building new centers to have that one-stop shop for cancer patients.
The thing that really limits fragmentation, because while one-stop shop is ideal, most organizations haven't gotten there yet and may never get there, particularly those who are so geographically dispersed that they may not be able to, across all their geographies, have that one-stop shop. The thing that's really critical in limiting fragmentation is really that navigation role and that care coordination role. somebody who has the patient at the center continuously and allows these specialties to circle the patient, but they are really the home base for the patient to go to reinforce what the treatment plan is, but to also ask questions, to also make sure that they've got somebody to go to if they can't get into one of the specialists within the time frame that's needed to treat them. That's really important as we think about what applies to all programs and where are there areas of all programs across the country, no matter if you're a NCI designated cancer center or a community health system providing care. A huge area of focus is on navigation. I always use the phrase, someone that puts their arms around the patient and then holds them within those arms throughout that journey. Because when you receive care in the community, it's a lot harder to get that level of seamlessness and that sense of somebody's watching out for me versus when you have that in like a dedicated cancer center.
The nurse navigators is particularly important because of the clinical nuance and context of cancer care. You'll have sometimes a combination of clinic coordinator and nurse navigator because we know that cancer care is complex. It requires multiple subspecialties. It does take a village when we look at that system of care. It really is cancer care across the continuum. Gaps in the early phase can impact your inpatient or outpatient growth, and not having true services in the middle portion, which is the acute care, radiation, infusion, can impact long-term retention and growth. When we think about the long-term trajectory here, it's not only about being comprehensive, getting the latest and greatest new technology, it's also about being connected as a system and as a program.
So well said. Setu, Melissa, Ryan, thank you so much for joining. This has been a really rich discussion, and I just so appreciate you sharing your expertise here.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.